Well, welcome back to Value Based Care. I am excited to be here with Dr. Shawn Seibert, who I feel like I've worked with him for so long that it's really fun to be doing a podcast and be talking through a
Yeah, I
podcast.
agree.
But um, but I think everyone's gonna really love having you on our show because I've always thought of you as so enterprising and you have really interesting ways of thinking about medicine. And I wanted to be able to showcase a lot of your career, which you've had such a long career doing this interesting suspicion of cancer clinic and this model of trying to be proactive about cancer, but also not overly anxious because we don't know that it's cancer yet, but giving it that space. And so I wanted to invite you, Sean, to talk about what this model has been like, how it is evolved, what you're thinking about for the future, and how an oncologist like myself, and with your background with hospital medicine, but really you're someone who wears many hats, how it would be good for us to work together to have a partnership model.
Yeah. I think my story is a very unique story, and I think you have to understand my background, going back in the last 25 years to understand kind of where I'm at right now. I, grew up in Central Illinois, uh, born in the early '70s, and, basically grew up in the restaurant business. And I grew up waiting tables at a very young age, and so I attribute all of my skills to waiting tables. I feel like that's kind of the foundation of everything I've done from there on. I learned a lot of good lessons kind of growing up, for patient care, and I learned that, patients or at least, for customer care, that customers wanna have their food quickly, they wanna have their, they wanna have good quality, and, they wanna get it quick, and so, I think and they want it to taste decent, and so I think you can kind of compare medicine. I've always looked at medicine is, waiting tables, and so we're just doing it on a higher level is kind of my analogy, but so that's a little bit about my background, into childhood. I originally really enjoyed wildlife conservation. I enjoyed, spending time in northern Wisconsin, fishing. I've got pictures behind me here of some of the stuff I did as a child, and so I thought originally I was gonna, go to the forests of, Montana and save wildlife, and so my life took a little bit of a twist in college, and I enjoyed human physiology. Took a gross anatomy class, and it kind of changed the direction of my life. Went to ISU, Illinois State University. Graduated in 94, 95, and then got accepted to University of Illinois in Champaign, Urbana, in 95, and then graduated in 99. Did a 3-year residency in internal medicine with, OSF, University of Illinois, in Peoria, and so, graduated in 2002. After graduating, there was kind of a new there was, this whole hospitalist movement was kind of, developing. It had been brewing, I guess, for maybe 5 years or so. And so, one of the hospital administrators had approached myself and 3 other individuals that were in the graduating class of 2002. We were all internal medicine docs, and decided uh, to offer us the opportunity to start a brand new hospitalist group. And so, we were the first hospitalist in the city of Peoria, and, just to think of it, there were 4 of us that started, and now we have over probably 75 hospitalists in the city of Peoria. So it's, from and being the first, to where we are now, it's pretty amazing to see what's happened. And then throughout the nation, you've got probably 10,000 at that time, and then it's grown to maybe 60,000. So it really has taken off since 2002. To in After several years, I became the medical director, of the program, and so we grew to about 8 physicians, and it was really exciting developing. developing these interactions with physicians and trying to promote this whole practice. It was kind of a it was very exciting for me, kind of developing this whole new model. We weren't widely accepted. We had a lot of resistance, and it was kind of going into a time where physicians weren't really open to the concept. We had a lot of internal medicine physicians that kind of looked down upon hospitalist medicine, and and some gave up their practices quickly, and while others actually took a long time. Um, but it really was I learned a lot in the first 5 years, really trying to develop those relationships and being able to provide great quality service for those docs and really give good communication and feedback. And I learned a lot in hospital administration. I was also very involved in the operating committee, the executive committee, the finance committee. So I was really kind of embedded within the hospital system. So I really understood how the hospital thinks from their standpoint. So I think that was very good early on. There was some interest for the hospital administrators wanted me to develop a career in administration. I was reluctant to at the time. I might have gone that direction, but I wanted to do patient care because I really love taking care of patients. Um, all of a sudden in 2007, so I'm 5 years into being the medical director at the hospitalist group, and I got a page on my phone and it basically said Illinois Cancercare. And so, but at the time it was hockey, oncology, hematology, Central Illinois, and I responded, called up, and basically it was the CEO of the company at that time, and she said, "Hey, we'd like to talk to you about becoming an oncology hospitalist." So I said, "Well, I'm always open for, I'm always willing to listen." That's one thing I've learned in life. I've always tried to say yes. I've tried to never turn down opportunities. I guess that's one lesson I would pass on to any fellow healthcare, providers is always try to be open for change and say yes. You can always say no later, but listen to what people have to say. So I decided to meet with uh, Mike Voller, John Kubler, who was in our practice at that time, and then Paul Fishkin, who's still with our practice, and they had a discussion. They were looking for an oncology hospitalist to cover a 48-hour shift, Saturday morning from 6 a.m. to Monday morning at 6 a.m., and I would have to cover 3 hospitals. And as it turns out, I decided in about 4 days. I thought it was an excellent opportunity. I was a little nervous, but, here we are 19 years later, which is actually hard to believe. We're gonna be 20 years into next year, that I've been doing, the weekend, coverage for Illinois Cancer Care.
Yeah, it sounds like you've been through a lot of innovation and having to start out in some ways uh, treated like a beginner, even though really you're at the time ahead of your time doing this hospitalist model. Really interesting that you took that listening approach, just being open-minded. It sounded very humble. Makes sense that you waited tables and you told about that story because you really would have to have that servant leadership type of personality to grow this kind of a program and work for so long for a company too. And so that shows a lot of different sides of your character, which I think are really great that most people already know about you. But also, I think your interest in education, I think that's also very, it comes out very clearly. You spend a lot of time being able to just enjoyably teach people everything that you've gone through, medicine itself. I can tell you light up when you are educating patients. And that also, I think, is very uh, speaks very highly of your character too, because you could say 20 years later, you're so senior now, you don't need to be doing all that. You've gotten a role now, you're above that. You can just delegate, but you still have that very interested, want to be a part of the change. I think all of that is really refreshing to be able to work with someone like you. And so that's in case you're wondering why I'm always weird and stalking you, that's part
Oh,
of
no, I appreciate that. It's you know, we live in a at least in healthcare, we know the pressures that we have, and it's always trying to see patients in a, shorter period of time and keep going to the next patient, and, and I understand we're running a business. Um, what I try to balance that with really taking time with patients, and we can get into some of the details of the new clinic that I created, which was the Suspicion of Cancer Clinic, where I've been able to kind of build that from the ground up. And I wanted to make this a really exceptional experience with the patient, almost like a boutique practice where you spend an hour with them and you kind of go through that. And we can certainly talk about that, but I really wanted to take the best of medicine, and I think I've got the greatest job, in the country. I feel like for healthcare, I really am doing exactly what I want to do, and I'm kind of discovering, almost like an investigator trying to figure out what's going on, and it truly is internal medicine. And so what I'm doing is basically nothing more than internal medicine, but really getting to spend time teaching, going through imaging with patients, and when they leave, hopefully making them feel a little bit more comfortable about, what's going on. But I can certainly go I can maybe I'll take a step back and just go back just a little bit kind of in the beginnings of the clinic and kind of get into some of the things that you were talking about, kind of how I've incorporated that into practice. But um you mentioned something about oncology hospitalist work and how it's um, maybe kind of a new innovative thing. Just to give you an idea, when I would go to some of the hospitalist meetings in 2015, I would go to the Society of Hospitalist Medicine meetings. I've been going to those national meetings for hospitalists since the early 2000s. And sometime around maybe 2015, I met a group of oncology hospitalists. There was this breakout session and it said oncology hospitalist, and I couldn't believe it. I was so excited, and I was like, "There's somebody else that's doing what I'm doing, and I haven't talked to anybody. I haven't met anybody that was doing this." And so at that time, back in 2015, we got together in a room, and there was maybe, I don't know, 8 of us. There weren't that many, and it was really interesting. And one of the individuals that I met was from MD Anderson, and so this physician, I got to know him at the next meetings, and then so each year, and then um, in 2016, 2017, at that next year, he invited me down to MD Anderson to kind of explore to see what oncology hospitalists were doing. They had just started, or they were working on a fellowship program for oncology hospitalists, so a year fellowship, and I think they were actually the first. There may be one other fellowship accredited program in the nation, but I was really impressed by with what they were doing. So I went down there not knowing what to expect, going down to Houston, and spent some time inpatient, and stumbled across some of these ancillary clinics that they had. And so all of the ancillary clinics were run by internal medicine physicians. And so they had preoperative medicine, they had like a geriatrics, they had side effects from immunotherapy. I mean, some really innovative things. I think in a big academic center like that, you're going to have these niche areas to keep these docs busy. But then they had a suspicion of cancer clinic, and I was really fascinated with that because I've always been, you know, interested in diagnosing patients faster. Because is one of the things in hospital medicine, and one of the things I noticed over the years when patients would get admitted, I would hear some stories where they were bounced around for many months. They weren't diagnosed quickly. They couldn't get in to see a provider, and then finally they wind up in the hospital with stage 4 disease. And I would just hear some tragic stories over the years, and it kind of struck me that this might be a valuable clinic. And so I went over, met with the program director. They shared some information about an hour, kind of got to hear kind of the big picture of what the clinic they had to offer. MD Anderson gets a lot of patients from all over the country, and these individuals sometimes don't have a diagnosis. I mean, sometimes they fly into MD Anderson and they have a mass or something that's unusual. So MD Anderson said, "Hey, we need to figure out how to get these patients off of the oncologist schedule because we don't have a diagnosis. And so if we could create a clinic to offload all of these people coming into Houston that want an answer, we could maybe expedite that." And so I think it worked out well for their model. At the time, this was 2016 when I went to MD Anderson, um, I was not aware of any other suspicion of cancer clinic in the nation. And so, I decided to came back to Peoria, kind of talked to the group about it. There was some excitement initially, and then kind of some time went by, and I happened to be invited to a meeting accidentally. One of our partners couldn't make it last minute, and they said, "Shawn, do you want to go?" I had had a good relationship with this hospital system because I actually was in their administration and I worked with them, so they kind of had me tag along. And these healthcare systems sometimes, oftentimes, at least at this time, we had kind of a maybe colder relationship. We were trying to generate some collaboration, if you will, and, there's 2 healthcare systems in our region, and so we were trying to generate some ideas for their healthcare system, what we could do and offer for oncology, and so I kinda kept my mouth shut at the entire meeting. I kinda listened to what everyone had to say, and then kind of at the very end, I just said, "Hey, I've got a great idea. I think I just was down at MD Anderson and I saw this suspicion of cancer clinic model, and I kinda went through it in detail and what I thought we could do, the now CEO, said, "How soon can you get this started?" And so that was kind of the beginning of this whole process. I was very excited. I was kinda shocked that, wow, someone actually, I mean, the CEO of a healthcare company just didn't even question and was ready to make a move on this concept. So basically, uh, I took the next 4 months to really dive into each specialty that works up cancer, including radiology, interventional radiology, GI, pulmonary, and I met with all of these different specialists, and it was really exciting for me just listening to physicians and hearing the problems in their particular area, and everyone has their own challenges, and I took a lot of notes, and I really listened to what was going on in healthcare. In each region, you could probably go into any city, any region, and you're gonna find there's different challenges. So that's the most important thing is really go in and figure out what are the challenges in your system, and after I was able to put all that together, I was able to go we went live about 5 months later, and I had a blank slate. They told me, "You can pretty much do whatever you want. You can build the day the way you want." And so I went ahead and we started with, um, kind of a team meeting in the morning, and so we decided I wanted to MD Anderson had hinted that they have a team meeting to kind of discuss kind of a round table, and I wanted the social workers, and I wanted, we had navigation. I was kind of embedded within the healthcare system, and I worked with navigation. And I was able to form this team, and we were able to kind of meet each day and talk about, or each day that I was working to talk about, okay, the patients that we're working on to try to expedite through the system. How can we speed up this individual? So we would problem solve during that first hour. Then we would also talk about the patients that we were gonna see that day and what we needed to do, and so we even had a plan ready for each one of these patients. Even before I would walk in the door, we would go through imaging, I would look at everything, and we kinda trained the whole team on what to look for, and so this was an educational thing for really everyone, and so I felt this was really exciting to be able to go through this and kind of educate all of the navigation team and other support staff. So, we started, and then we went from working Tuesdays, and then we started to get fairly busy. I presented the concept to several group meetings with, many of the primary care providers. This institution has probably about 170 primary care providers. I was able to meet with a lot of the leads of each practice, and, we grew slowly, finally into 2019, 2020. I eventually moved to 2 days a week, so Tuesday, Thursday, because we were filling up. We were having a lot of primary care providers wanting to refer patients in, and they were really accepting it. Even to my surprise, they were really very, very um, excited about our program. And so I didn't realize how many challenges there are for primary care in terms of getting patients worked up, or sometimes just questions on working up cancer. And so, and it can be very difficult. I think it's very challenging for some of these providers. And I think sometimes they struggle on who to send these patients to. And I think they were sending them to oncology. And so we'll talk a little bit about burnout and how we can relieve that. But I think it was the same issue that was going on at MD Anderson, but just in a different type of, maybe not outside of the city, but these were primary care providers that were just having some challenges, or nurse practitioners, maybe they, or ER, just having some challenges trying to refer patients in. So basically, so big picture, about 8 years we have been going in the suspicion of cancer clinic, and the last 4 or 5 years we've been doing 2 days a week. I brought in a nurse practitioner probably maybe 5 years ago, and then that nurse practitioner, I've had 2 or 3 different nurse practitioners. They're actually owned by the healthcare, um, basically the healthcare system, and so they bring in that individual, and then they work with me side by side, and they cover me when I'm not there. So they're there full time, and they're actually fielding the calls, and that's really helped out a lot because I was taking calls all the time on days that I weren't there, and I had a really, really good nurse with a lot of experience. But it's really made life a lot easier for me to have a nurse practitioner there and kind of field these calls as they would come in. But that's a little bit of kind of the big picture in terms of where we are. So, basically, um, right now I function is um, I guess just looking at the big picture in terms of what we're providing for the healthcare system. We're roughly providing, according to our data at Illinois Cancer Care, I ran the data from 2025. We're seeing about 35%. All the 35% of all referrals to Illinois Cancer Care from this healthcare system, from the Carle healthcare system, is funneling through our clinic. So we're seeing about 35% of all those cancer cases. And so that means out of the 170 primary care providers that are working in this system, um, about 35 percent of those are basically referring those cancer patients through our clinic. Um, what's also interesting is we get a lot of people that are outside of our healthcare system, both systems, and they're from 2 or 3 hours away. They hear about our clinic. They can't get into a provider. They call up and they come in quickly. We usually get them in quickly, and we also were starting to see patients from the competing healthcare system. Um, a lot of patients can go either they can go to anywhere their insurance allows them, and so they hear that they can get into a someone to kind of diagnose their cancer or possible cancer. They're very worried they can't get into a primary care provider, and am having the competing healthcare system, even their physicians are even referring, because they really want what's best for the patients, and they're trying to get these patients taken care of. So I found that has actually been quite interesting, is when you create a model that really is successful, you get a lot of you get a lot of interest from patients and even self referrals, ER, and even competing healthcare systems, which has been which I've been surprised with.
Yeah, I really appreciate that immersion because I really felt that picture getting painted of how you've built this over time. Not even an idea, which it is a great idea, but also the relationships, the network that you created, and all of the people that you probably spent so much time building relationships, listening to them, knowing their problems. Like sometimes when I hear these stories, there's a direction that goes upward, like almost like building an ivory tower, so to speak. And it's the person gets higher in title and higher in role, but in listening to you, it sounded like you got more immersive, like you understood the primary care doctors and felt for them. And they have really a very hard job. And so when they refer to us, they're putting a lot of trust in our hands. And same thing with the nurse practitioners, like they probably feel like they have a very specific role in medicine and they could be much better appreciated, utilized, fulfilled. And you really built that kind of relationship across institutions, across private, public, academic, community. It seemed very much from your story that you really, like, we hear this all the time, you really care about patients, but it really feels that everything you've done builds upon that. And it could only really work if it were based on how much you just really want patients anywhere, whoever that is, to benefit, to be taken care of. And so I really appreciate hearing the story straight from you because it's such a positive story and it's not very easy to come by um, that kind of a very honest, sincere story of just you put in a lot of work as opposed to like the heroic story or like something that may sound very exciting and charismatic but is not very realistic. I think it's something younger trainees can really learn from and they gain that wisdom of just knowing the day to day is very important. It's not just the kind of the grandeur of the large scheme.
I think
So
one of the things I would tell, um, some of the new physicians coming in that maybe are concerned about burnout or, one of the things, and I've been very blessed to have the opportunity to have my full-time job and create this, which is basically moonlighting. This was not required by the group. This was a separate, to me, I pursued this on my own because I was interested in really trying to change, or expedite the care and really get that diagnosis for patients quickly. And so I think when you have that, drive to change something and you're able to create something, even like your own business, you feel like it's not work. I enjoy going in, I enjoy doing it, I enjoy taking that responsibility, and every time I get a phone call from a doctor that wants to get this patient in, or maybe the ER wants to get somebody in, I always ask every patient that I see, "How long did it take to get in? How long did it take for the referral?" And they'll say, "Gosh, we got a call yesterday. I can't believe we got in one day." And so I tell my patients, this has really been the drive, and it's one simple goal that we've had, and we've kind of built this clinic, and every single nuanced thing that we've tweaked and adjusted, and every month there's new things. Every week there's something new that we learn, especially early on, and we've been able to refine this process down, um, from everything from radiology to navigation to, um, bypassing the referral system to some degree, having the connections with the PET scan and CT, having the connections with interventional radiology, pulmonary, kind of fine tuning the whole process. And we've been able to put that all together. And it's really been rewarding for me just to kind of focus on that one goal, which is how do I get a patient in quickly and how do I get them treated quickly? And so, how do you compress that down? And so, if you just have one simple goal in whatever whatever clinic you're in or whatever you're trying to do, I think sometimes if you just keep it simple, and really you can build everything around that. And in healthcare, you'll win every time if you can figure that out. If you can figure out how to get patients in this environment, I feel like healthcare is, and you may agree with me, I've never had such a challenging period, at least within the last year or two, of getting patients in quickly, you know, just having issues in the healthcare system where we don't have the specialists. We just don't seem to have staff. And it seems like after COVID, we've had a lot of challenges in healthcare. And I think it's even more important for healthcare to figure out to come up with these innovative ideas to try to get patients through quickly. And, one of the challenges I believe in oncology is not necessarily just getting in to see an oncologist. I believe the real problem that we have is moving the um, moving the oncology model to the left, which basically in the tech world, when you move a model to the left, what you're saying is you're trying to figure out how to get those individuals into whatever you're trying to do. And so w- we're trying to figure out how to correct this problem of early diagnosis, getting people in quickly. Obviously the screening and all these different things make a difference, but really getting these patients in quickly, getting them diagnosed, triaging them. And I think oncology, I believe we need to own this process. And I believe we could work together to create this type of a model kind of on a national scale, and be able to teach other physicians, internal medicine physicians working with APNs, to kind of move this model to the left and be able to focus on this area, which I think is a huge challenge, which maybe is even more of a challenge than getting in to see an oncologist. It's getting people diagnosed quickly. And so if you can figure out how to address this with with the challenges we have in healthcare right now, just getting in to see a physician is a challenge, a primary care provider, but providing that outlet to get those patients seen, and then teaming up with oncology where we own the process. We educate someone who's maybe cross-trained like myself, who has maybe inpatient experience. I do a hematology clinic, as you know, and then also tying in a clinic like this, and where you can tie in all those areas of expertise. And then what I'm doing is I'm offloading work for oncologists to make their burnout, to basically to help them avoid burnout. And we have to figure out something, and this is just one model. I think it's worked well at Illinois Cancer Care, and to me, I think other practices would, if they could kind of create this model, I think they would be extremely happy in the results, or with the results.
Yeah, it's one of those things where, because I have worked with you so long, it seems that it's almost like I took it for granted how just how much you had to think and envision far into the future to be able to do what you're doing. And it's really such a joy to see that you wanted to do this, like you wanted the change, you took that initiative. It's very hard to find people with that kind of spirit. So I feel very lucky that we can work together, and I get very drawn and magnetized by you talking about this model because I can tell you care about it. You text me about it. You
Sorry
Teams
if I
message
bother
me
you.
about
Yeah,
it.
I know I send you, and I
I
see
love it.
exciting cases. I can't help it. So
Yeah, and I think you're even giving a big talk at Community Oncology Alliance. I think there's a big conference coming up, and
yeah,
so
that's it. It's been
yeah.
a great. I was kind of surprised. I was invited to talk about this subject matter. I think this is something that um, means a lot to oncology practices, and U.S. oncology. I think when Dr. Busby had heard about this concept, and he actually came to the Doc Rock celebration in November, and I had a chance to talk to him, and I think he saw enough there that he then said, "Hey, maybe come on out to Arizona, and we're gonna have some leadership, and we're gonna have kind of an innovative." We're talking about they're gonna have different subject matters, but kind of looking at the future of oncology and where we see ourselves and how we can plan for the future. And I think he saw this suspicion of cancer clinic model as maybe being an innovative model to shift the model to the left, to be able to pick up, those patients in oncology where we can actually kind of help get those patients into the system faster, and where we can help primary care. So I'm very honored to be invited to that, and hopefully I'll be able to share, and I'm excited to talk to some of the docs out there and just share what we're doing here, and hopefully I can help them kind of create the same clinics where they're at.
Yeah, and I'm glad you mentioned the Rock Doc Award because that was very well deserved that when you won that. I still remember when you found out and you told me, and you were like a little kid who got all the ice cream in the ice cream shop.
It was exciting.
Yeah, but very well deserved. I think it was not at all a surprise when everyone found out. It's like, oh yeah, Dr. Seibert would of course win Rock Doc Award. So,
It was
but
a great it was a great honor. No, I really appreciate, there's a lot of great physicians that have been acknowledged over the last many years, and so I was very honored, and I was honored that my team actually I think this is the first time in 16 years where both nurse practitioner and physician, both people who won the award are in the same clinic model. So that really I don't think that's happened before. So I was really excited that we both, were able to share in the award with my nurse practitioner and being able to change care and kind of, get things get patients through the system quickly and expedited. So I was very very excited to be able to kind of to share the model with the community.
yeah, yeah, and for the audience members who don't know about Courageous, it's a local community award, and I think of it as very hard to find a community event where everybody comes together and it's not about the competition and it's not about all those harder things that can be very divisive, and it's more about looking at all the value that individuals have brought to the community and built over decades. So I really enjoy seeing that kind of event, although I'll admit I missed it. I am not as cool as I should be go to all these nice events. But yeah, I was really happy to see that you and your nurse practitioner won together because it shows that the community really values collaboration and harmony, working together. There's a lot of difficult realities in healthcare, like you mentioned, but I think everybody just wants to learn how do we get back to working together and everybody having, I use this term abundance, which might be a little bit overplayed or a platitude at this point, but I still believe in abundance, which is we grow the pie. Yeah, there, we cut it, but that's because we can also grow it. And so I really am appreciative of being able to chat with you because it seems like you have that very abundant style. Like even as you talk, you talk like a business person, and I know you do a lot of things, not just medicine, and that weaves into a lot of your wisdom and how you practice medicine too, because you have so many different views on how to do things. So yeah, yeah, it's really great. Please go ahead. I feel like I always talk
No, no.
so much and
I think I've hit I mean, I think we've kind of hit most of the topics. I guess, no, I appreciate that feedback. It's been a little bit of an overwhelming year just, um, with the accolades and everything, and so it's like Mike Voller, our CEO, said, I think Sean's not gonna be able to fit through the door, his head is gonna be too big," and so, we always joke about that, but I try to I do try to remain humble, and every time I see patients and, it I think it helps ground me when I'm in the clinic, and, I really I'm excited that we're able to get patients in quickly, and it really gives me a drive to see if I can even make it even better and see if we can expedite care. Um, one of the things I would mention is I'm getting ready to submit a study, and we're waiting on the editors made some revisions, and so um, we did take we looked at our data and wanted to see how well we were doing compared to other academic centers. Being a community based center and doing some of the things that MD Anderson is trying to do, I wanted to see in this model where we take an internal medicine physician working with a nurse practitioner, where we see all cancers that come in through this clinic in a suspicion of cancer model, where we don't just work on disease specific, which is kind of the model that you see everywhere throughout the country, where you see a lung clinic, or you may see a prostate or GU or GI. The concept is we're just going back to our traditional roots of internal medicine, and we're basically filling that in. I have an analogy that I like to use, which is we have, what's happened to healthcare is we've lost, when I first started, we had internal medicine docs, we had quite a few outpatient internal medicine physicians, and now we don't have so many. And we went from, you know, we now have 60,000 internal medicine physicians that have basically been taken away and they're hospitalists. And so we no longer have the internist. And back when I started in the early 2000s, internal medicine docs took pride in working up cancer, and they would not hand the patient over to oncology until that patient was taken care of and when that patient was diagnosed. And so it was really it was considered, you weren't a very good physician if you were looked down upon if you didn't do a good job and basically do the workup. It was just kind of expected as internal medicine docs. And so I think that's changed a little bit, but the real challenge is we have a system where we have, I think, um, using the military as an analogy, we have privates and we have generals, and we've lost the lieutenants. And so what's happened is we have the specialist as the generals, and we have primary care as kind of the privates. And so they're overwhelmed. They're seeing a lot of cases, and maybe they're under, they're being put under pressure for RVUs in production, and they can't take an hour to go through and look at CTs and basically just do what really needs to be done. And these patients that have potentially cancer, they are time consuming. And so, what I think basically what we've done is we're trying to pull back. At least my vision of the future is trying to tap into hospitalist medicine again and go in and train these hospitalists on their week off and pull them into this clinic where we can actually use them and train them in an outpatient clinic doing internal medicine, because they're basically doing it as hospitalists right now in the inpatient setting. So it makes sense if we could train them to kind of build this model and fill in this model. And I think we could replace that lieutenant where we create this silo of care, which we help primary care. We partner with them to really do all of the stuff that we're really good at in terms of understanding how the system works. And if you do a lot of one thing all the time, which is just looking up all cancers and diagnosing them and getting them through quickly, you understand how the system works and you get really efficient at it. And so then everyone business increases, and you're going to stay very busy because you're doing a good job. And so I think that's really just kind of the big picture in terms of the future, and looking at where I think we go from here. So my vision is really trying to take those hospitalists and trying to talk to some of these hospitalist companies and collaborate with them, and potentially eventually work with US Oncology, where we can tie these two models in together, with hospitalists working with oncology and creating clinics like this to get people in.
Very much hear from you how much you desire to provide value. And that's an important lesson, I feel like very, very refreshing, especially for uh, the up and coming generation of doctors when they're faced with burnout and provider shortages. And like you mentioned, it's getting harder to get patients in quicker because of so many things that are changing, like digital technology, learning curves. So being able to have that perspective that is very much, well, what value am I adding? How can I help the situation? I think that's really, it sounds kind of like you said, simple, but simple is really all we need, as opposed to the very prevalent, like, what do I get out of this? Why should I do this? There was an easier time. Why is it harder now? Like when it becomes more about the individual and less about the community, I think burnout is much more inevitable. But you've seemed very resilient to me, even all the things that you've been through. And you're like a really tough guy to me because you've had this positive outward look. Like is this value add? If it's not, then let's start talking a different direction immediately. Like very humble, very much wanting the community to thrive. And so I really hope that the audience takes that away, especially the generation up and coming looking at all the problems. And I'd say look at all that, that pride that you have. I feel like you worked so hard and you have such a great feeling about it, and that's something to look forward to. And really thank you so much, Dr. Seibert. I feel like I am always cutting you off because you have so much to generously share, and I'm just like, I could.
No, I love working with you. Not many physicians, are open to, sit and listen, and I know that, this is why I think maybe this podcast, this concept, I think is gonna work well because you're willing to listen and take in new ideas, um, and, you're basically, you're just I just love working with you because 'cause you're such a kind person and you're very empathetic, and I think we can balance medicine where we combine empathy, productivity, innovation. I think there is a solution, and you have to find it, and so if you don't have it, then you need to find a career that you can enjoy it, and I've been very blessed because our practice at Illinois Cancer Care, and this is just something to point out and give them kind of a gold star for this. They've let me kind of develop this on my own, and they've let me kind of run with it. And even the hospital system, I have to give them a gold star as well because they didn't interfere. They let me create this. And there's something to be said when healthcare systems and managers don't micromanage things too much. And if they let the physician that's interested in really making a change and going in and creating something new, this is how we innovate and we make things better. And sometimes by micromanaging things, sometimes we don't always see that side. And I think a lot of physicians are frustrated because they're not able to innovate. And some of us like to innovate. And to me, that's what really drives me is trying new things. And especially in healthcare, there's a lot of different, options. We have a lot of challenges, and so there's a lot of opportunities for all healthcare providers in their niche area.
Yeah, and I'm gonna thank all of the audience for listening to Value Based Care once again. And I hope everybody has a great week.